Hey team, welcome to the MMOA podcast. I'm Macy Bolt, outpatient PT and TA with the older adult division of ICE Physio. Today we are going to get into the nitty gritty of a patient who ended up with a functional quad palsy after a total knee replacement and how we took her from frustrated to functional in 12 weeks. We are going to dig into which interventions worked and which interventions were a total flop when it came to her recovery, and discuss what I'd do differently if a patient presents like this in the future. So Cindy is the patient we are discussing today. Prior to her knee replacements, her knees had been very limiting to her for about 8 years, with a very gradual course of deconditioning where she stopped doing the things that she previously loved to do, including walking her multiple rescue dogs, gardening, and doing exercise videos, which included getting on and off the floor. Fast forward to this past July, when Cindy had her first total knee replacement. Overall, she had a very uncomplicated recovery and her range of motion came back beautifully, but her strength remained quite limited. We were able to gradually increase her quad and hamstring strength. However, she really only tolerated open chain activities because her other knee was also needing to be replaced. And anything closed chain really aggravated that contralateral side. Now, in hindsight, this should have been a little bit of a warning sign to me. But truthfully, because we knew her other knee replacement was scheduled for 8 weeks after her first one, our focus remained on the newly replaced knee at the time. Eventually, we did hit a point in her recovery where we were so limited by her other knee that in an effort to save visits for the second recovery, we elected for her to continue with her home program for her first knee leading up to that second replacement. So fast forward then to her first visit after her second total knee replacement. We started by doing the basics really well. We got her range of motion going, we started to get her quad activating. But during that first visit, her quad set was poor at best. It really didn't matter what position we were in, what facilitation techniques we were using. That first visit was pretty tough, which is not all that uncommon. I saw her soon enough after her replacement that her nerve block was still in place. And so this often does happen when that nerve block is still kind of taking over. Unfortunately, this lack of quad function continued on for about 3.5 weeks. And we tried everything. I mean, everything to get her quad to wake up. We did assisted quad sets and straight leg raises. We did E-stim. We tried cupping. We tried tactile cueing, external feedback, working in gravity minimized positions, and trying to get a crossover effect by using the other leg. Nothing was working. She was really heavily relying on the walker still because her knee was buckling when she walked, and she couldn't do the stairs at all, which is something she has to do at home because of her instability. She was using her first knee that was replaced to do almost all of these activities and really limited with her newest knee. So at this point, we had been in contact with the surgeon and they had repeated imaging just to make sure all the components were in place and rule out anything insidious going on because this was kind of an atypical presentation. Ultimately, between the surgeon and what we were seeing clinically, we determined she likely had a quad palsy from neural aggravation during the surgery or right after the surgery. Her surgeon, thankfully, is someone that I work very closely with. So we were in really close communication this whole time. And he felt really strongly that this was not going to be a permanent deficit. And this is just something that was going to take time to return. So overall, reassuring for the patient, but didn't give us any immediate solutions to get her going. Then what she and I did is we pivoted. We decided we were going to change approaches and we went for the functional approach instead of focusing on kind of that isolated deficit that seemed to really be hindering her. Without a doubt, quad function is imperative after a knee replacement, but given that everything that Cindy and I had tried had been unsuccessful so far, it was getting to the point where Cindy was getting really down on herself, and her recovery was really starting to negatively impact her mental health. Of note, Cindy's husband is in the early stages of dementia, and she is transitioning into a caregiver role for the first time in her life. So with her recovery being slower than expected and not typical, she really was starting to kind of feel dread and panic and spiral a little bit over the idea of not being able to be a caregiver for her husband, whose needs were significantly increasing. So When we think about what our role is in this situation, sometimes it goes beyond what we typically think of as rehab providers. This is what we call in the ice physio world resource stealing. So, what was really key here is that based on what Cindy was telling me and sharing with me about her concerns, I was able to get her and her husband connected with a social work team. And they have been awesome at helping them find resources that have been really, really key in decreasing Cindy's burden so that she could focus back on her own recovery while also making sure that her husband was taken care of. So that included getting him ride services, some respite care so that someone is at home with him while she's coming to appointments, things like that, that were really burdening her and didn't come up until kind of midway through our time together. If you are interested in learning more about kind of the span of our roles as rehab providers and how to become a resource dealer really well, we cover this in our L1 online course, and we would love to have you join us for an upcoming cohort. So once we decided we needed to shift our approach to PT, what we did was take a step back. And we reframed and we looked back at Cindy's initial goals, which were number 1, walking her dogs, number 2, getting back into the garden, and number 3, returning to her workout videos on the ground. Inherently in recovery, Cindy knew that we were working toward those things, but by really verbalizing it and shifting our perspective, it helped her morale so much because she felt way more connected to the interventions that we were doing. And I immediately saw a change in her demeanor really during rehab. So during our first session, after we kind of flipped the script, we did 3 interventions the entire session. Number 1 was upper extremity assisted sit to stands. We focused on slow eccentric lowering to an elevated chair. I put an AirX foam pad on the seat of the chair to give it a little boost. And then on the ascent, we used verbal cueing of pushing the ground away to come up to standing. So she was pushing the ground away to come up, and we were moving in slow motion to come down. This took the cueing from internal to external, which worked really, really well for Cindy. We both knew that she had this uncooperative quad muscle going on, but by taking the cueing externally, she wasn't thinking about her quad the entire time. She was thinking about pushing the ground away. So then exercise number 2 was staggered stance weight shifts, doing kind of a stride step in a sense. The newest knee was forward, and we were in the parallel bars. So she had upper extremity support on both sides. And I cued her to stomp through her front leg during that weight shift. So she was stomping forward, rocking back, stomping forward, rocking back. The idea with the stomp is trying to wake that muscle up, get that leg doing a more effortful movement to try and stimulate that muscle activation. And exercise number 3, we did a modified Spanish squat with a band behind the newest knee, anchored to the parallel bars, and she was holding on. So what she was working on was unlocking her knees and then locking her knees. And the cue that I used for locking the knees is that she was going to crush the band when she pulled back against that band. So then these 3 exercises became her home program. And as you can imagine, she had a lot of things on her home program before this with us trying to get her quad to wake up. So this really simplified what she was working on as well, which was awesome for time management, in addition to just feeling a little more productive with those exercises. So we scratched all of the basics, and we went to these 3 very functional exercises. She came back the following visit, and she reported feeling more stable on her feet and feeling like she wasn't relying on the walker quite as much. So during that next visit, we started to transition to working with the cane, which went way better than it had been previously, but she still fatigued really easily. So then we really focused on those same 3 exercises, but decreasing the amount of upper extremity support that she was using during those same exercises. I am a firm believer that simple is key in a lot of scenarios. And this was that scenario where we didn't change everything up because it was going well. We kept consistent, but decreased the support with it. So then over the course of the following 2 weeks, we got her doing every single one of those exercises without upper extremity support. She at that point was walking with a cane all the time and not using the walker at all, which was awesome. And So she's 7 weeks post-op at this point, feeling a lot more confident, but still struggling with a standard chair height or getting off the toilet, doing the stairs at home. And every time we talked about getting on and off the floor, it was panic mode. She really was freaked out by the idea of that, and even more freaked out about a potential fall with her ending up on the ground and not being able to recover from that. So if you have been to any of our live courses, we discuss the idea of using power-based movements to help when strength might be limited in order to help patients achieve success with whatever that movement is, whether it's reaching overhead, whether it's getting on and off the ground, whether it's getting in and out of a chair. And so this is exactly how Cindy and I pivoted next. So we started working on a sit to stand, but we used a stomp to stand approach. So she would literally rear back in her chair, stomp through her feet, and swing her arms and use her whole upper body for momentum to come up to standing. So that first visit that we did that, she was able to do 1 repetition before she fatigued. She is now up to doing 10 repetitions using that same approach and is so much more fluid with that movement. That same visit, we also started working on lateral step downs on a step. We started with a 3-inch step. We are now up to a 7-inch step, focusing on a slow eccentric phase and a push through the foot to pop back up with that powerful ascent. So using power was greatly beneficial to making sure that Cindy felt like she was getting some oomph back in her movement. So then the next hurdle to overcome was the fear around getting on and off the ground. As with many, many patients who've had total knee replacements, she was really hesitant to kneel on her knee. So where we started was 2 weeks of desensitizing that knee. So she would stand facing a chair that had a cushion or a pillow or a blanket on it, and she would just weight shift onto and off of that knee. Now, as I mentioned, she had both knees replaced. And so I made sure that she was doing this on both sides at home to make sure that we're getting both sides less aggravated, less sensitive when we do get to that weight-bearing position with the knees. So once we got through kind of that early desensitization, she was feeling pretty good. And she was feeling like, okay, I think I'm ready to try getting on and off the floor. We started this. I'm fortunate to have a big mat table at my clinic. We started this on the mat table, pretending that the mat table was the floor. And so I put a chair on top of the mat table. And what we started with was working on quadruped to tall kneeling with upper body on the chair, and then working on the transition to half kneeling, bringing her legs up and around to make sure that we can get her into that position to kind of push through her legs and her arms at the same time. We did that for about 3 sessions, just getting that really feeling nice and fluid, nice and smooth. And each session, there was less cueing from me, less assist from me. And she got to the point where she was doing that phase of things independently. So then we have the day that we got her down onto the floor. And we used a technique that we teach in the live course called the backward chain method to get her down. She got down kneeling onto a pillow on the ground. And she immediately burst into tears because it had been years since she had been down on the floor. So we took a moment there. She, at that point, was not sensitive through her kneecaps at all. And so she just hung out there for a minute, collected herself. We took our time. And then when we went to transition off of the floor, she required moderate assistance from me. I had a transfer belt on her, so lots of loops and things for me to grab onto. And so that was a moderate assist on my end to get her pushing through her legs and back up. The key with this was she was so fatigued after that 1 repetition that that's all we did that day. We did not try this again after that because I don't think that would have gone as well as the first repetition did. So in subsequent sessions, we have just continued to increase the repetition, decrease the assist from me, and at this point, so we are about a month out from that first day that we got her on and off the floor, she can now independently string together 7 repetitions on and off the floor in a row without any assistance from me at all, except for setting up the environment. In my eyes, this is a massive, massive success for someone who couldn't do a straight leg raise 2 months ago. Cindy is so happy with her improvement. And we both know that we have a lot more work to do to get her strength and endurance where we want them to be, but we are well on our way toward her goals. So let's recap. If I could go back, there are 3 specific things that I would do differently. Number 1 would be pivoting sooner to doing the functional tasks versus the isolated exercises, because in Cindy's case, this made such a huge difference for her progress and her morale. Number 2, focusing more on her contralateral side during her first knee recovery. I think that would have set us up for success so much better when we transition to treating her second knee. And number 3, I would have loved to dig into her caregiving responsibilities sooner so that we could have connected her with the social work team prior to her replacements to decrease her burden as a caregiver and allow her to focus more on her own recovery. And finally, the things that I think made such a massive improvement in Cindy's recovery are: number 1, reframing her plan of care based on her specific goals. Knee replacements, we often think of that recovery as being pretty similar no matter who it is. I disagree. In Cindy's case, having her specific goals guide our care made all the difference in the world. Number 2, focusing on function to allow her to have more carryover to her quad muscle that was lagging in recovery. And number 3, really taking time to listen and letting Cindy share her emotions and feel them all during our sessions. She has had a very long road in her recovery and is dealing with a lot personally. And allowing her to share that has really helped build our therapeutic alliance in the best way and really has created this mutual trust. Thank you so much for listening. And if you are looking for more ideas on how to best care for your older adult patients and learn some of the techniques that I talked about today, please join us at an upcoming live or online course, which you can find at ptonice.com. Also, click the link below to receive our bi-weekly MMOA digest straight to your email with tons of great clinical tidbits. Can't wait to see you soon.